and a very good morning to everyone here. Today we'll be talking about to demonstrate the adjunctive role of intravitreal anti-VEGF injections in rapid resolutions of intraocular tubercular granulomas. So choroidal tuberculomas are the most common forms of intraocular TB. The high vascular supply of the choroid favors this location of the tuberculomas to form. Most cases lack a definite tissue evidence, and the management is relied upon clinical presentation, systemic involvement, and response to treatment. Most cases are unilateral, but there can be multiple cases also. Yellowish with indefinite borders located in the posterior pole. They have a varied presentations in terms of hemorrhage, stry, or exudative retinal detachment. There is minimal associated inflammation. Tubercular subretinal granulomas are responsive to ATT. It has been proposed in literature that increased levels of VEGF may be responsible for the vascularization of these granulomas. Pharmacological inhibition of the
Timer is not working. Timer.
Should I continue? Pharmacological inhibition of the VEGF pathway limits the spread of the MTB, causing regression of the new vascularization, thus achieving a host-directed therapy along with the ATT. In recent years, there have been multiple reports of successful use of anti-VEGF for the treatment of tubercular granulomas. So we'll be discussing a couple of cases. So this was a 25-year-old male, a student who presented with diminution of vision in the left eye for 1 month, which was painless and progressive with no aggravating and relieving factors and no contributing significant history. The vision in the left eye BCVA was 360, IOP anterior segments was within normal limits. When we see the posterior segment, the inflammation was minimal, and if you focus on the red arrow there, you see a massive subretinal mass almost engulfing the disc, and you can see the disc being absolutely choked with multiple hard exudates at the macula. This is the corresponding OCT showing the fluid there and an amalgam of multiple hyperreflective foci here, suggestive of a strong inflammatory reaction that's going on. So we revisited the history. Father had pulmonary TB 2 years ago and was treated for the same. Among the battery of investigations that we did, we found a positive MAN2, a positive TB quantiferon gold, and a suggestive chest X-ray. We took a physician referral, and ATT was initiated along with the steroids, and we gave in this intravitreal anti-VEGF plus dexamethasone plus moxifloxacin injection under mannitol cover, and AC paracentesis was done. We gave 2 doses at 14 days apart. We monitored the patient for clinical picture, IOP, BCVA, vitals, and blood sugar. So this is after 1 week of post-injection, and you can already see, you can make out the disc features, and the granuloma has started shrinking. The edema, which was massive that time, has come down, and then we re-injected the patient, and here we see a near normal OCT. The disc features have come back to normal as compared to what we had started with an absolute choked disc. The BCVA was 6/6. This is all happening within a month of initiating therapy. Case 2, 36-year-old male as a shopkeeper, diminution of vision in the left eye for a month, no known comorbidities, no contributing history. Again, the left eye, 6/60 BCVA, IOP anterior segments all within normal limits. Now here we see there is this mass here, which in contrast to the other one doesn't look that aggressive, although the OCT shows us that the disease is pretty much active. So we went through our protocol, and the positive investigations we found was positive MAN2 with the quantiferon gold and X-ray. Again, ATT initiated with steroids. We gave in the injections along with the mannitol and the AC paracentesis, 2 doses, 14 days apart, and monitored the patient. So we can see that within the first injection, the granuloma is almost gone, and the OCT has come back to near normal, although the fluid is still there. And followed by the second injection, where this is almost like a normal fundus photo, and the OCT is also returning back to normal anatomical ranges. BCVA was 6/9. So ocular TB is a form of extrapulmonary TB presenting as uveitis in endemic countries like ours. The classic histopathological finding is epithelioid cell granulomas with a central area of caseating necrosis. VEGF is a known biomarker for TB, and there have been reports of that the serum VEGF level of patients in active TB decreased parallel to the improvement of the disease. VEGF is highly expressed in the inner macrophage layer, the active layer that surrounds the necrotic core, and the bevacizumab normalizes the granuloma vasculature, reducing hypoxia and enhancing the penetration of ATT. Paradoxical worsening of IOTB due to an immunological reaction is known. The reason why steroids may need to be increased to intravenous corticosteroid therapy. In the last decade, there have been multiple reports highlighting the adjunctive roles of anti-VEGF. Agarwal et al. Showed in their study the non-regression of granuloma was responded to the injections of bevacizumab plus moxifloxacin. So did Bansal et al. In their study. And Ivan is in our first case, as we saw that the disc was choked. This one, he again showed how the injections of bevacizumab helped reduce the disease pathology. So anti-VEGF drugs ensure equal distribution of all therapeutic agents in the granuloma, thus significantly reducing the chances of MDR, TB. Moxifloxacin preferentially accumulates in the macrophages, the active zone, so the intravitreal moxifloxacin is used to target the active component to have a higher penetration of the disease. The highlight of the paper was the use of intravitreal bevacizumab plus moxifloxacin along with the standard ATT plus steroids. So this was our study to demonstrate triple therapy in resolution of intraocular TB granulomas, which is a targeted therapy promising faster results in anatomical and clinical resolution, although larger numbers are required. Thank you.
So how can we be sure that the systemic treatment is working or the aggressive intravitreal dose is affecting? These things are doing in conjunction.
Yes, ma'am. So, ma'am, as we know, tubercular granulomas, whenever we start treatment, the standard is to give ATT along with the steroids. And there have been multiple literature reports that yes, this is there. But then there are these factors of MDR TB that comes in. And then there's this factors of non-resolution, like the exudative retina detachment persisting and the edema persisting, the disc being choked. So it's a longer protracted course. There have been studies which have shown VEGF levels to be increased, both systemic and in aqueous aspirates, although the vitreous biopsy would be a better analysis, but aqueous aspirates have shown high levels of VEGF. So when we are giving this anti-VEGF injections, ma'am, the VEGF is going down. Also, it is reducing the vascularization that is happening along the granulomas. So it is shrinking that, which is helping in more better disease penetration, therapeutic penetration to inhibit the drug. And there have been serial reports where when we did aqueous aspirates in the patients post the anti-VEGF, we found the VEGF component going down in the aqueous with, as we saw the study, the anatomical reduction of the granuloma, ma'am. Sir. 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 Yes, sir. Yes, sir. Yes, sir.
Hemopoietic disturbances, parasitic infestations,
Yes, sir.
focal sepsis.
Sir.
Because I am a very old school of thought. I have passed my MS from SM Medical College in 76.
Sir.
So you give a lot of lectures on this eels.
Yes, sir.
And you, those old things, they used to give the anti-tubercular
Yes, sir.
drugs in this.
Yes, sir.
Have you seen the case of eels?
Yes, sir.
So what is now the modern modality of the treatment of eels now?
So basically, as we know, EELS is the diagnosis of exclusion. And once we are confirmed that this is okay, we are dealing with a patient of EELS. So yes, we go with the normal protocols of giving the ATT and the steroids. Depending upon the clinical picture, if the vitreous hemorrhage is clearing up, the FFA lights up neovascularization or capillary non-perfusion areas, we go in for an aggressive form of a laser. If there is an associated TRD, tractional retinal detachment, we would warrant a VR surgery. If it's a non-resolving VH, sir, then we plan to go ahead for a vitrectomy, and if the retina is attached, we will compound it with an intravitreal anti-VEGF.
Thank you very much. Thank you.
Sir.
So, Dr. Indranil, is there any role of FFA in this?
Yes, sir. So FFA would be helpful to corroborate the diagnosis. Yes, we did not, but in our cases, we did not go for the FFA here. I mean, both FFA and ICG would have been helpful, but we don't,
Yeah.
we don't have an ICG access. And the FFA, we did not go for because we were more towards to, once we got the OCT and the clinical picture, sir, so we were more prone to go in for a therapeutic role. And the FFA was planned as a plan B if the response wasn't coming as desired. So that was the FFA plan, sir.
Next speaker.
I think we can go on to the next speaker now.
Thank
you,
you.
Dr. Indranil,
Thank you.
for that presentation. And can I call upon Dr. Sarab Chabra, please? And I request the next speaker to keep their presentation ready on the other podium. Sir, please come this way. So Dr. Sarab Chabra will be presenting on novel perspective in choroidal osteoma. Can I confirm who are the speakers that are present in the hall, please? Please raise your hands. Name? Okay. Thank you.
Good morning to the esteemed panel and all the delegates present in the room. Choroidal osteoma is a benign ossifying tumor of an unknown etiology, which is characterized by mature bone replacing the choroid. The purpose of this paper was to report a diagnostic dilemma in a case of a chorioretinal lesion. A 28-year-old female patient presented with painless progressive blurring of vision in the right eye of a duration of 5 years. Symptoms of this blurring started at 5th month of pregnancy. Only the right eye's vision was affected. It was finger counting 1 meter for distance and N24 for near. RAPD was observed in the right eye. The cornea, iris and the lens were normal. On retinal examination, both eyes showed orange-red peripapillary lesions deeper to the retina with marginally defined scalloped margins located within the macular area. The right eye additionally showed presence of fibrous scarring and clumping of brownish black pigments in the foveal zone. The retinal vessels and the peripheral retina were unremarkable. This is the fundus photograph of both the eyes. On investigation, an ultrasound B scan was done, NCCT orbit was done, and in the end an FFA was also done. The ultrasound B scan and NCCT orbit had similar findings showing bilateral linear echogenic foci and bilateral curvilinear calcifications along the posterior wall of the eye, both of which suggested bilateral choroidal osteomas. Hematological investigations showed a raised ESR, raised TB1 and TB2 values on ELISA, and IgG markers positive for rubella, CMV, and herpes simplex virus. This is the ultrasound B scan photograph. There as a posterior echogenic, there is a shadow which is observed. These are the corresponding FFA images. For treatment, usually the only treatment which is given is observation if there is no progression of disease or any neovascular membrane is not observed. So in this case, the patient was started on eye drop Nepafinac and indomethacin capsules and multivitamins, which were given only for 1 week to begin with. Anti-tubercular therapy was also started on the first weekly follow-up. The patient was called for follow-up weekly for a period of 3 months. The patient responded to systemic and topical anti-inflammatory therapy. Vision in the right eye improved for distance as well as near. And during this period of follow-up, multiple retinal imaging and scans were done, which showed that there was no development of any CNVM, hence no intravitreal anti-VEGFs were advised. The radiology suggested choroidal osteomas but the presence of systemic tuberculosis may have had an etiological contribution to the diminution of vision, hence why the patient responded to anti-tubercular therapy as well as anti-inflammatory therapy, which was given along with. This statement is corroborated by the improvement of vision. Usually choroidal osteomas are are only observed if there is no progression or growth which is seen along the margins, but they are also associated with multiple systemic conditions. So there should always be a high degree of suspicion when choroidal osteomas present to us for systemic diseases which may be present in the patient. So adequate control and early detection of those diseases can be done for proper treatment of the condition. Also, we should be on the lookout for any sequelae of RPE atrophy and choroidal neovascularization which may occur, so that intravitreal anti-VEGFs, if required, may be given. Thank you. Thank you.
So, thank you for the presentation. I wanted to know what was your differential when you saw that patient?
Sir, when the patient was examined in the OPD and indirect ophthalmoscopy was done, the first treatment or the first investigation on the day itself, we had sent the patient for a B scan, and when that showed shadows behind the retina, so the first differential was any sort of calcification. So the first differential was a choroidal osteoma, and others were chorioretinitis, any other form of any other chorioretinitis.
Any form of role of FFA and ICG in this first?
Sir, FFA. So when we were thinking, when the chorioretinitis was in the picture, a late chorioretinitis was in the picture, then that is why the FFA was done. But there was no characteristic hyper or hypofluorescence which was seen, which would suggest or go in that direction. And the B scan images and the NCCT images were already available at that time, which had showed calcification. So we did not progress further in that direction.
Did you do anything else, any other tests like an ultrasound, and did you rule out any other systemic conditions in this patient?
All the any other systemic conditions like
Any other systemic associations along with the osteoma that you showed in
no,
the body?
Ma'am, only the tuberculosis and the basic because it started during pregnancy. That is why we did tests for torch and TB having high predisposition and prevalence in our country. That is why we tested for TB via ELISA.
I just want to know one thing.
Yes, ma'am.
Why anti-TB was started?
Ma'am,
Because the choroidal osteoma, they have very particular picture.
Yes,
So
ma'am.
that is very specific, and
ma'am.
the calcification you have shown on the B scan,
ma'am.
that is very specific for the
Yes, ma'am.
that is the osteoma. And why anti-TB was started?
Ma'am, because the patient had raised levels of TB1 and TB2 on ELISA, so it was started for the patient was treated for TB along with.
But the patient was pregnant also.
No, sir.
Yes.
The symptoms started when she was 5 months pregnant. This duration of diminution of vision was 5 years. The
5
symptoms
years.
started when she was 5 months pregnant.
And
you completed the course of TB, or you left it in between?
No, sir.
Just
The
15 days.
TB so she is currently under treatment.
Okay.
So this patient presented to us about 5 months back. So currently she has not finished her 6 months of TB treatment.
I think you said that it was initiated, but then was it completed?
Sorry,
What is
sir?
the role
Ninth
of
month.
completing it also?
Yes, sir. When the patient is expected to come to us next month, then we will again do follow-up scans. Sorry, sir. The TB treatment, you mean?
Yeah.
Yes, sir. It has been initiated, and the patient is undergoing treatment for
So I
tuberculosis.
think, as even ma'am was asking, were there any systemic associations, anything to do with tuberculosis that you initiated, and then you've continued the TB treatment?
Sir, just cough and poor appetite. That's it. The patient did not have any other symptoms which would suggest for tuberculosis. It was just a general checkup that we did, which showed raised tuberculosis 1 and 2 levels on ELISA.
Okay.
Can I just ask,
inoculated in Lawrence Johnson's media and he demonstrated the histology.
Sorry, sir?
Can I ask Dr. Deepti to take the podium?
I mean to say that did she have a pulmonary tuberculosis or extrapulmonary tuberculosis?
Sir, probably extrapulmonary because she did not, apart from cough and a diminished appetite, she did not, the patient when she presented to us, she did not show any other features.
So she was put on ethimetol.
Sorry, sir?
Was she put on ethimetol?
Sir, we referred the patient to the, from what I know, sir, she was not put on thimetol. The regular rifampicin, pyrazinamide, isoniazid, the regular therapy was started.
The thing is that in the modern, at present, the mode of treatment is ethimetol.
Yes, sir.
But when you put basically on the ethimetol, you have to basically see that ethimetol does cause color changes,
Yes,
changes
sir.
in the fields.
Sir,
It does cause optic neuritis, which is dose dependent. So all the treatment,
sir, yes, sir. Sorry, I did not hear you clearly. Yes, sir. Sir, the patient is on ethambutol. We have also given her. Every time she comes for follow-up, color vision is also done, and she is also.
you chuck the optic disc.
Sorry, sir.
I mean, you chucked the fundus, particularly the optic disc, because the thimerosal is known to cause optic
Yes, sir.
neuritis,
Yes, sir.
which is dose dependent.
Yes, sir.
And if you reduce the, if the does that optic
Yes, sir. So that the retinal examination is done every time when she comes for follow-up.
Thank you. Thank you.
I call upon Dr. Deepti to present the correlation of glycosylated hemoglobin with retinal nerve fiber thickness and central macular thickness in the diabetic population in North India.
Requesting all speakers to stick to their time and requesting the next speaker to come to the podium during the discussion. Up next is Dr. Sachin Rohela. Thank you.
Good morning, respected judges and delegates. I'm Dr. Deepti and my AIOS ID is D27136. And I'm going to present my study on correlation of glycosylated hemoglobin with RNFL thickness and central macular thickness in diabetic population. Diabetic retinopathy affects nearly 90% of individuals of diabetes, and the American Diabetes Association has recently defined diabetic retinopathy as highly tissue-specific neurovascular complication involving progressive disruption of interdependence between multiple cell types in the retina. HbA1c can also be used as an effective tool for diagnosing patients who are at high risk to develop complications including retinopathy. So the aim of my study was to correlate HbA1c level with RNFL thickness and central macular thickness in the diabetic population in northern India. My study was a cross-sectional observational study done in Regional Institute of Ophthalmology IMS BHU over 450 patients over a duration of 18 months after proper committee ethical approval. All the participants were divided into 3 groups. The first group was healthy controls with no systemic or ophthalmological issues. Group 2 included patients with less than 7 years history of diabetes and without diabetic retinopathy. And group 3 included patients with more than 7 years of history of diabetes with mild to moderate NPDR. The inclusion criteria being patients with type 2 diabetes and age above 18 years, and exclusion criteria being best BCVA below 1 logMAR unit and other causes and other associations causing RNFL loss like myopia, severe severe NPDR, PDR, glaucoma, etc. So the first fasting blood sugar, postprandial blood sugar and HbA1c were compared using unpaired t-test between patients with no diabetic retinopathy, mild to moderate NPDR and control group, and later any correlation present between HbA1c and 4-quadrant RNFL thickness and CMT, central macular thickness, was found and correlation graphs were plotted. Coming on to results, we found in the baseline characteristic features of the participants, we found there was no significant difference between the mean age and gender of the patients between the 3 groups. However, there was a significant difference between the best corrected visual acuity of both eyes, fasting blood sugar, postprandial blood sugar and HbA1c levels. On RNFL thickness, we found there was significant difference in all the 4 quadrants of both right eye and left eye. And then we did correlation graphs. We found no significant correlation in group 1 between HbA1c and RNFL thickness, and in group 2, that is diabetics without retinopathy, we found significant difference only in inferior quadrant of left eye, and in diabetics with retinopathy we found significant difference in inferior and superior quadrant of right eye, inferior, superior and nasal quadrant of left eye. And these are the correlation graphs between right eye 4 quadrant RNFL thickness, which is showing a negative correlation. And this is also the correlation graph between left eye 4 quadrant RNFL thickness and HbA1c, suggesting negative correlation. Coming on to central macular thickness, we found significant difference between the 3 groups in both right eye and left eye, and then the correlation was plotted. We found there was weak positive correlation in the diabetics with retinopathy and without retinopathy, but which was not significant. And this is the correlation graphs between bilateral eye central macular thickness and HbA1c of group 3, that is diabetics with retinopathy. Coming on to discussion, Mehboob et al. Found that the mean RNFL thickness and RNFL thickness of 4 quadrants both was found to be significantly thinned out in diabetic population. Dasmana et al. She found significant RNFL thinning only in superotemporal and upper nasal sectors in patients with retinopathy, while our study suggested RNFL was thinned out significantly in all quadrants of both eyes in diabetic patients. Oshiatari et al. Found the CMT was significantly thicker in pre-proliferative retinopathy and then that of the no retinopathy group. Jamali et al. Found CMT to be increased in with increasing stages of retinopathy and bad glycemic control. And our study also suggests the CMT to be significantly increased in diabetics irrespective of the state of retinopathy. The limitations of my study were that RNFL thickness and central macular thickness were evaluated at one point of time and long-term follow-up was not done, and also the ganglion cell thickness was not analyzed. So we concluded that RNFL was found to be thinner in patients with diabetic mellitus when compared to control with statistically significant difference, and CMT was also found to be thicker in diabetic patients with statistically significant difference. However, the study indicated a negative correlation between HbA1c and 4 quadrant RNFL thickness in diabetics with retinopathy, and we found weak positive correlation between HbA1c and CMT in diabetic group with or without retinopathy, which was not significant. So my take-home message is monitoring RNFL thickness could serve as an early indicator, and glycosylated hemoglobin also indicate about RNFL health. These are my important references. Thank you.
What was the reason for doing this study? I mean, how does it add to literature which is already there, and what is the clinical correlation that you want to derive from this? What's your take-home message from this?
Sir, the take-home message is while we do HbA1c level, we can correlate with RNFL thickness, and also we found no such literature in the northern India population correlating HbA1c levels and RNFL thickness and central macular thickness.
I have a question. All these cases, they were not lasered?
No,
That's
ma'am.
what I want.
No
Any
ocular
exclusion
treatment.
criteria?
Ma'am, exclusion criteria being all the other causes of like RNFL loss, like myopia, glaucoma, severe NPDR.
Lasered.
No, ma'am.
That.
Laser was. All the patients were did not undergo any ocular treatment. It was done prior to it.
If you have no questions, we can go on to the
Okay.
next talk. Thank
Dr.
you,
Sachin
ma'am.
Rohela, is he present? Dr. Anusuya Kapoor. He's present? Dr. Sachin Rohela, you're present. Please come forward. Ma'am, we'll next to you.
Good morning, everyone. I'm here to present vision loss in idiopathic intracranial hypertension, a rare case presentation. A 44-year-old obese male resident of Dehradun, Uttarakhand, present to the OPD with painless diminution of vision in right eye since 4 weeks. He also has history of pulsatile headache since 1 month, which was not relieving with medication, no history of long-term steroid use, and he has past history of tubercular pericardial effusion 1 year back and took anti-tubercular treatment for 6 months. General physical examination within normal limits and systemic examination within normal limits. Visual acuity in right eye is lowered down to finger counting at 1 meter and PR accurate, and in left eye 6/6 and PR accurate. Pupil reaction in normal in size, normal in reactive in both the eyes, and direct and indirect reflexes are present in both the eyes. IOP and rest of the ocular examination within normal limits in both the eyes. On fundus photography, red arrow showing blur 360-degree blurring in the right eye, green arrow showing vessel obscuration, yellow arrow showing disc margin blurred, and halo round disc states of grade 2 papilloedema. On OCT, we have red arrow showing subfoveal neurosensory detachment. Systemic examination. MRI brain is within normal limits. On consulting with neurophysician, lumbar puncture was done, showing opening pressure was 28 centimeter of water with normal CSF component. So diagnosed as idiopathic intracranial hypertension. We have final diagnosis is idiopathic intracranial hypertension with right eye subfoveal neurosensory detachment. We gave him treatment astazolamide 250 mg QID for 2 months, napafinec multivitamins, and on follow-up we give him same astazolamide 250 mg BD for 1 week, and we stop. Then we have improvement in symptoms, that is finger counting 1 meter to 6/36, improvement in headache, and papilloedema also got resolved, shown in this picture. Treatment on 2 months treatment, papilloedema resolved, and both eye have disc pallor present. On follow-up OCT, RNFL thickness decreases, that is, a red arrow showing subfoveal neurosensory detachment got resolved. On discussion part, visual consequences of papilloedema usually are limited to visual field defect and enlargement of blind spot. Macular abnormality such as intraretinal macular edema and hemorrhage occasionally causes visual acuity loss in papilloedema. Cases of subretinal macular edema in papilloedema are not well documented in medical literature. Hence, we reporting a case of 44-year-old obese male with anti-tubercular treatment for tubercular pericardial effusion since 3 months, now presented with complaint of headache since 1 month, with sudden painless diminution of vision in right eye since 1 week. So, ophthalmologists need to differentiate between visual loss secondary to optic neuropathy from vision loss due to macular abnormality, and study by JL-Best concluded that 1 to 2% of IH cases also have present with blindness in a given year. I am emphasizing on the part that all patients with IH need to kept under long-term follow-up with regular monitoring of visual functions. So here are some references. That's all. Thank you.
Thank you for your presentation. I wanted to know, was there any role of steroids in your case, and do you recommend your take-home message to do MRI in all such patients in the first sitting, and a lumbar puncture, as you said?
On lumbar puncture, if we have...
do you refer all these patients for an MRI and an LP?
All these, no.
Or
but maybe in some cases.
Cases with papilledema is
Yes,
what
ma'am.
I'm
Yes, ma'am.
asking you.
Yes, ma'am.
All patients undergo MRI? When you see clinically cases with papilledema, how do you manage them?
In papilloedema, we first go for fundus photography. We see there is a papilloedema is present. Then we go for treatment like first treatment like astazolamide to resolve that edema, and we also looking for sign and symptoms of papilloedema, for to rule out like optic nerve lesion, like we go for visual function test, visual field, and then pupillary reaction, and then many other things like color vision.
Sir, I would like to ask you this question, whether IV methylprednisolone would have helped in this case, because I had
That's
a
what I
similar
was trying to
case.
ask. That
Yeah, can.
role of steroids is also.
Ma'am, can I just, So wonderful case. I just, as ma'am was saying, I believe any disc edema in this kind of a case, one would definitely go for a neuroimaging over there. I just wanted to ask, how are the pupil reactions? I mean, I think I might have missed the point there.
In this case,
Was there a-
no,
was
pupil
there an
reactions are
RAPD?
normal in this case.
Pupil reactions.
Are normal in the case.
Any history of any drug intake?
Yes, ma'am. Anti-tubercular treatment, ma'am, for pericardial effusion, ma'am.
Okay.
So, you said that there is a rare, this is a rare entity. So, why do you think it is rare? In
Because
what way?
in IIH case, we don't have patient have blindness, but in this case, we have patient present with finger counting at the 1 meter.
What was the cause of blindness in your case? What do you think?
If disc edema is present, then there may be blindness due to presence of a tissue like known as intermediate tissue of Kunt, present between optic nerve and retina, like a cushion. If that disc got disturbed, then we have patient macular edema like finding, and then patient may present with
I don't
optic-
think that macular edema really corroborates to the vision that the patient is presented with, and I don't think that see, it's basically transitive fluid, so that much of edema will always be there, but I don't think that's the reason for the vision loss in any ways. So ultimately,
Sir, could it be a pre-existing with an ATT induced
yeah,
optic
it could be
neuropathy?
something, yeah. So
Because there's a history of ATT
and
induction
secondly,
there.
you really
But
don't.
no, color vision is within normal limits. No
With I
red
think
green.
the vision being counting finger, at that time, I mean, even color vision to assess would be a
would
little
not be-
challenging.
Yeah.
When you have that poor a vision to assess color and contrast would be a little challenge.
That is normal within normal limits.
Thank you.
Can we just, for a minute, take a minute to confirm who is present to amongst the speakers? Dr. Shaireen Naz, Dr. Anupam Singh, Dr. Ankita Rao, Dr. Adil Arman, Dr. Jayanti, Dr. Shivangi. So I think we'll go ahead with Dr. Sumi Gupta is here. Dr. Anusuya ma'am, please continue. Please start. Thank you.
Yeah, good morning everyone. I will be presenting a case series on multimodal imaging of Coats disease with macular nodule mimicking retinoblastoma. So in 1908, George Coates first described the Coats disease as a congenital retinopathy in young males characterized by retinal telangiectasia, subretinal exudation, capillary non-perfusion areas, retinal detachment. Macular nodule in Coats disease has been described in Western literature and has been reported to have an incidence of 23 to 53%, but surprisingly, no study from India talk about macular nodule as a presentation of Coats disease. Like this particular study, including 280 patients of Coats disease, none of the patients were reported to have a macular nodule. So we looked into our 339 patients of Coats disease, treatment-naive Coats disease, and we found out that 7 of them, that is 2%, had a macular nodule at presentation, which were included for this study. We documented all these, and we found out that the mean age of these patients with macular nodule was 6 years. They were all male, unilateral presentation, the median best corrected visual acuity being CFCF. And interestingly, all patients were diagnosed with retinoblastoma and referred to our ocular oncology clinic. The most common presenting complaint was decreased vision, followed by squint and white pupillary reflex. The macular nodule was located in the fovea in majority of the cases or between the superior arcade and fovea. The color was grayish white, either it was dome shaped or bilobed, and there was subretinal exudation around the macular nodule in all the cases. There was pigmentation in 57% of cases. The second or third order retinal vessels entered the nodule and continued till the apex. 1/3 of them also had calcification. In the fundus, the peripheral typical telangiectatic vessels were noted, most commonly in the superotemporal periphery. There was subretinal exudation and subretinal fluid in some of them. Moving on to the OCT features, it appeared as a well-defined subretinal nodule involving the outer retina, RP, and Brooks membrane. The inner retinal layers were disorganized. The ellipsoid zone and ELM were disrupted. There was a lot of posterior shadowing surrounding exudates, no fluid. We could also note dense localized hyperreflective areas of RPE aggregates. On ultrasound, it appeared to be a eco-dense mass with a highly reflective A scan on the surface and also sometimes inside the mass whenever calcification was there. On fundus fluorescein angiography, at the macula, early and mid-phase hypofluorescence with focal leakage, indicating a vascular etiology, and in the periphery, the typical light bulb aneurysms with CNP areas were seen. Primary treatment for majority was laser photocoagulation and scleral buckling and external SRF drainage for patients with retinal detachment. At a mean follow-up of 8 months, the best corrected vision acuity was maintained in all cases with no significant vision gain. So just to summarize the differences that we noted from what characteristics are reported for macular retinoblastoma, these patients had xanthochoria, were older in age, all males, unilateral presentation, whereas retinoblastoma was in a younger age group and also had seeds or hemorrhage in AC and vitreous. Just a note on the nodule, this nodule is grayish white, the surrounding exudation is there for all patients along with pigmentation, whereas in retinoblastoma it's a fluffy white nodule with feeder vessels and calcification. And the periphery is the giveaway, look for the telangiectatic vessels there along with exudation. On OCT, it was a subretinal nodule, whereas retinoblastoma is a full thickness retinal mass. On FFA, there was blocked fluorescence because of the exudates and pigmentation, and in the periphery, there were the light bulb aneurysms and CNP areas, which was not the case for retinoblastoma. Calcification was more common for macular retinoblastoma. So this is the first Indian study on Coast disease with macular nodule. It represents a vascular process. Here we have first time described in detail the layer by layer OCT characteristic of these macular nodules. The poor prognosis is basically because of the degenerative changes in retina. It is of utmost importance that we are aware of the typical fundus appearance and adjunctive imaging features of this entity to differentiate it from retinoblastoma and treat appropriately. Thank you everyone for a patient listening.
This is a very interesting presentation that you've made. And really appreciative of the fact that you noted these findings. But for my understanding, you know, when you see peripheral telangiectatic vessels, so a diagnosis of Coats is very much evident. So what made you feel that this study should be done?
Yeah, so the reason, as I said, all these 8 patients were referred to our oncology clinic with a diagnosis of retinoblastoma, and one of these kids have also received a chemotherapy. That urged us to do the literature review, and when we found out there are no Indian studies, so it's worthwhile to report the features, because despite that peripheral telangiectasia that is missed, and people do confuse it with retinoblastoma.
Yes, so I think a comprehensive indirect ophthalmoscopy
absolutely
in all these cases will make things much simpler.
Absolutely. And the exudation, which should have been the takeaway.
Yeah. So now that you've done this study, what do you think is like the one point where you would still confuse it with retinoblastoma?
Yeah, so the presence of macular nodule, as I said, it is very rare, like only 2% of our population had it, and like the pathogenesis is misunderstood. So for everyone here, the one finding, the macular nodule might look similar, though this is more grayish yellow compared to the fluffy white what we see for retinoblastoma, but what we should look for is the surrounding area of exudate. And what she said very correctly, the peripheral telangiectatic vessels should be looked for whenever in doubt to give away the diagnosis.
It means the B scan and the OCT findings and the clinical picture, the peripheral examination, all these things will contribute
yes.
To differentiate between these two.
Yes.
Thank you,
Thank
ma'am.
you.
Wonderful,
Wonderful presentation.
Dr. Shaheen Naz, Dr. Sumi Gupta, Dr. Nidhi Tomar, Dr. Anupam Singh, Dr. Ankita Rao.
I think there are no
If any
presenters.
more speakers are present, please come forward. Dr. Adil Arman, Dr. Jayanti Shakya, Dr. Shivangi Verma. I think it's
I
an
think
early
none of-
session and
it's an early session.
so I think we should,
Call it a day.
yeah, wind up.
Thank you so much.
Thank you so much for attending the first session of UKSOS free papers.
I think if speakers are here, we can have a picture with the speakers.
Yes, yes.
and-
I think all speakers can come forward, please.
For a group picture.